Hi, Shail. Good afternoon.
Hello, good afternoon. So this is a elderly lady. She has an occludable angles in both eyes, and therefore a very shallow anterior chamber. We have decided to give an injection mannitol in the preoperative time before actually dilating the patient, because they suspected that she does get sometimes attacks of angle closure on dilatation. So I think that's one good important tip in such cases of shallow chamber, that you do have an option of pre-operatively preparing these patients more appropriately. I like to make limbals incisions. The first is a side port incision that I make. Following that, I inject an intracameral xylocard, preservative free, which in topical anesthesia I think does help the patients significantly to calm them down. It does sting a little bit to the patients when we inject them, therefore you'll always see that wince a little bit. And I always like to follow the technique that Dr. Steve Arshinov has taught us for several decades, which is the soft shell technique. So first, what I'm injecting here is a dispersive viscoelastic, which is viscoat in this case. And then I'll be injecting a cohesive viscoelastic of sodium hyaluronate, which in this case, I need Helon Pro. So, which in this case here is a Helon Pro, which is 1 milligram of sodium hyaluronate per 10 ml. So that helps to create space. So the viscoat protects the endothelium, and the Helon helps to create space to do the capsulorhexis. Then once the chamber is formed, that's when I like to make the second incisions, because so there are less chances of hitting the capsule at any point of time. And then I like to make my main incision. I always like to do a wound assisted incision, which means I use a spatula in my left hand to first pull the globe away so that I position the keratome at the limbus, and then I pull the globe with my left hand towards me while pushing the keratome as if I want to go and hit the corneal endothelium. So it's a single plane incision. I'm not dipping the incision at any knife at any point of time. I typically always like to operate under complete coaxial. My preference is for a needle cystitome based capsulorhexis. This being a shallow chamber, I'm a little more conscious, because as you can see, even when I'm turning it in, it tends to sort of go out a little bit more than what a normal capsulorhexis would do. So I'm quite cognizant of that fact.
Shail, do you have a number for the anterior chamber depth that you just need to be more careful or put more OVD?
So I think any endothelial depth less than about 2.5 millimeters is something that I am little more cautious about. And I think what is more important is that the depth from the from the endothelium of the cornea to the anterior capsule is what matters more.
Yeah.
So in this case, it's 2.3 millimeters.
Okay. And this is something, we get a lot of data in our IOL master printouts. Most of us don't look at it beyond the lens that we've chosen. But if you're doing a shallow chamber, you want to know that it's 2.3 and use more OVD, or you're more careful. And also the lens thickness is something we don't look at during surgery. But if you're going to groove or you're going to pre-chop, I want to know if it's only a 3 millimeter nucleus rather than a 4.5.
And I also like to always remove the capsulorhexis, so that in case if there is any tag that has been left at the area of the joining, it sort of comes out. And that we follow as a routine in our center, so that because if there are trainees who are operating, that will make sure that there are no bridges. Before I start my phacoemulsification, I once again inject a dispersive viscoelastic. If I can put some HPNC on the cornea, that will make the cornea a little more moist and lubricated. Yeah, and I'll use a chopper in my left hand. Yeah. So I first enter the eye in 0 position. So my phaco probe, I'll first make sure that the bubbles are out, because that's the most common thing, that if you don't squirt them out, you'll have bubbles immediately when you enter. And the first thing that I do is I just remove some of the excessive viscoelastic viscoat, which can typically clog the phaco tip and more chances of occlusion that keep occurring. So once that is done, I move to the sculpt mode, where this being not a very dense cataract, I'm using an Ozil of 30 only. And sometimes if after a sculpt or a first chop doesn't work out well, I even move on to, 4-quadrant if required. So this seems to be a relatively firm nucleus grade 1 plus or so. So I'll go, after having created a trench, I'll go to a sculpt mode, where I keep my Ozil here very low at 20, because I don't want too much of eating up of the nucleus to occur. And since this is not a very dense cataract, I'll reduce my vacuum to 300. So if you noticed, after occluding, I typically like to use my left hand to first create and initiate the crack and then laterally separate. Sometimes with the cortical cataracts and corticocapsular radiations in a soft cataract, the nucleus doesn't always rotate so well. So sometimes you may have to come out and rehydro. So first I'll just inject some viscode. And this typically does occur in what Dr. Ronald Yeo very correctly describes as sometimes what are known as neither here nor there cataracts, where it tends to cheese wire the moment some of the fragments tend to come out. And now since a crack has been created, there is less chance of sudden intralenticular pressure rise that would occur during the surgery. I'll rotate now with a chopper in my left hand and the Hoskin in my right hand, 1-tooth forceps in the right hand. Yes. So normally after doing the first hydrodissection, I avoid rotating the nucleus, because once a crack is created, it's relatively easier with the lever mechanism to rotate the nucleus. But sometimes you may end up with such a situation in a very softish kind of cataract. So in a soft cataract, sometimes even 3 or 4 quadrants are enough. And the first real challenge is to prolapse the first fragment into the chamber. So once that is done, you notice I've changed my tip to sideways, which will make it more surface shearing rather than actually occluding the lens matter. So a lot of loose epinuclear cortex that is left behind. So keep the Phaco probe right in the center, and I'm using very low parameters here, particularly in an eye with an occludable angle and a shallow chamber. So the intraocular pressure still is at 20, and my Ozil is still quite low, which is only about 20, and my flow rate I like to keep quite low. So I'm using a flow rate of only 20 cc per minute. So I think the advantage with the newer machines are that whatever you're comfortable with, the parameters that you are more comfortable with, you can use them to your advantage. So we typically like to use the lower flow rate and lower flow settings, and it still works quite well. And people who are used to working on higher settings, they also find it to be quite predictable to work in similar situations. So I think that's one of the major advantages, that you can titrate your parameters depending on your comfort level that you are used to working. And although this is not a very dense cataract, but I think that this balance tip, the major advantage that has occurred is that your overall energy settings have gone down significantly. So, if you normally have to use, say, 100, you'll only need to use 65, 70. So, about 30% less energy is required in such situations with the balance tip. So there is this plate if I can rotate and if I can remove it with the probe, I'd prefer that. And these white stuff that you see, those are the true corticocapsular adhesions. That really, they make them stick to the capsule, and therefore that is what makes sure that it doesn't rotate very well. I typically always like to form the chamber before I remove my Phaco handpiece. So again, injecting dispersive viscoelastic. And my preference is always to use bimanual irrigation aspiration. I think that gives us a lot of control on approaching each side and each area as and how you would want to require. I typically start with an intraocular pressure of 20 and a vacuum of about 300. And depending on if it is required, I may raise the IOP a little further as well. So I raise the IOP now to 30 and the vacuum to 350. And this is something that Viraj taught us very nicely. First is to occlude the cortex, then posteriorly detach, then swipe it. And only once you have completely detached it, then you start bringing it to the center and then press your foot position to end of foot position 2. So that helps to reduce the stress on the zonules and also will help in further, more complete removal of the lens epithelial cells present at the equator. So all of this that you see behind is the viscoat, which is very useful, but it can also, in sometimes like this, you have to actually remove it because it doesn't come out as a bolus. So these fibers on the posterior capsule, I change to the polish mode with a vacuum of 6 and a flow rate of 5 and an intraocular pressure of 20. And we'll just, it's gone off so nicely. So now we have a clear capsule. And yeah, we are ready to inject the IOL. Always prefer using a cohesive viscoelastic to inject the IOL. I know there are many surgeons who now prefer injecting under irrigation, but I think this gives me a lot more control to manipulate the IOL at different directions. So I typically like to load the lens myself. So first First I'll need this. Yeah, you can hold the cartridge. So this is a VVT IOL, the extended depth of focus IOL. And I think with so many options that now we have, the extended depth of focus IOLs have really helped or, increase the range of patients whom we can correct for some improvement over the monofocal IOLs. The best way is to make sure that you first fold one haptic on top of the optic and then with the forceps push the other trailing optic on the haptic, and I push it as much as I can right up to the edge of the cartridge. I typically like a shooter injector in most situations. So I always make sure I'm right there before I actually. So I'll use a Lester hook in my left hand. Again, this is a wound-assisted injection of the IOL, which means my left hand is pulling the globe to the center, and with my right hand, I'm injecting the IOL. So this is a 25 diopter IOL, so a slightly hypermetropic eye, and that is something that we expect with this kind of shallow chamber. So during viscoelastic removal, that's the only time I like to raise the bottle height and raise the flow rate, because I want to make sure that all of the viscoelastic is outside. So I start with an intraocular pressure of 20. First I make sure, there's some fibers here. First I'll try and make sure that the irrigation first goes behind the IOL. That will drive, the irrigation pressure will drive the viscoelastic from outside, and the aspiration, now I increase the IOP to 50, and the aspiration flow rate is at 40 cc per minute. And I always make sure that the aspiration port doesn't cross the IOL margin, although it's facing up towards the endothelium, so there's very little chance of catching the capsule. But these are some safety tricks that tend to come in useful in some special situations. However much you may, try and position the IOL or center the IOL to the Purkinje images, it will eventually center on the center of the capsular bag. And this is typically what we see. The rhexis doesn't always remain very circular in such eyes with some anterior zonular insertions and occludable angles. Irrespective of whether it's a toric IOL or not, it's a good practice to hydrate the wounds before bringing out your irrigation. Particularly, this would be very useful in a toric IOL, so that there is no forward rotation or circular rotation of the IOL that occurs. So hydrating all possible wounds. It's a fairly, if you can see, the incision is fairly long, which means I need at least a 2/3 distance between the anterior and the anterior lip, that is the external incision, and the internal lip. So since this was a 2.2 incision, I would aim at least for a 1.8 or a 2 millimeter incision. So I think we are done with the surgery, and thank you for the patience. And I think it was a good sort of live experience to show how many of us would end up in some or the other issues, particularly in a softish cataract. Thank you so much to the entire team here, the OR team, especially to Dr. Supriya and Dr. Sri Ganesh and Dr. Savio for taking care of us so much, and thank you to the audience for a patient observation.
Thank you, Shail. Great surgery.